Welcome to our Faces of Lung Cancer briefing for Lung Cancer Awareness Month, November 2024. My name is Dr. Rosalyn Juergens. I'm a medical oncologist practicing at the Juravinski Cancer Center in Hamilton, Ontario. And I will be your moderator for today's, I really think, thought-provoking discussion. Can I get next slide? My role is I am the Medical Advisory Co-Chair for Lung Cancer Canada, and I'm also a member of the Board of Directors. Next slide. We'll start our day with a land acknowledgement. Lung Cancer Canada acknowledges that our work and efforts take place on the traditional lands of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. These lands are now shared by diverse First Nations, Inuit, and Métis communities. This acknowledgement serves as a reminder that our commitment to advancing lung health must extend to all Canadians, including Indigenous communities, who continue to face health disparities with respect to access and outcomes, particularly in lung health. As healthcare providers and advocates, we recognize our obligation to support all communities, and Lung Cancer Canada is committed to working towards equitable access to care for everyone across this country. So I'm thrilled to have quite a diverse group of attendees today. We are joined today by healthcare professionals, advocates, researchers, patients, and their caregivers. The Faces of Lung Cancer report is our flagship publication each and every year, and I hope you look forward to being able to read it in greater detail. This year's theme is Raising Voices, Advancing Equity, and Changing Lives. Today's event focuses on breaking down barriers and amplifying voices of those impacted by lung cancer. On this slide, you can see our 5 priorities at Lung Cancer Canada. First, we are working on increasing survivorship through equitable access to lung cancer screening. Second, we're looking to improve treatment outcomes by breaking down barriers to biomarker testing. Third, we hope to ensure all Canadians impacted by lung cancer have access to the most effective treatments. Fourth, we are working to improve and save lives by boosting investments in lung cancer research. And last but not least, we're looking at advancing treatment through greater access to clinical trials. We have an amazing lineup of speakers and panelists today. We are going to be joined by caregiver advocates. We are going to be joined by patient advocates, as well as some of our physician champions. I'll be introducing them as they join on our speaker panels as we come along. I would also like to thank the Lung Cancer Canada team. We have an incredibly dedicated team that works at Lung Cancer Canada that makes all of these things possible. I want to point out that we've got a brand new website that launched earlier this year. So if you haven't been to our website recently, please come and take a peek at it. The content is absolutely spectacular. And so we have all sorts of wonderful things for honestly each and every one of you who are on this call today. I was just on the website the other day. We've put the website in the chat here. Just as a reminder, this Faces of Lung Cancer report briefing is being recorded. We will make the video available online. We anticipate that it'll be available on our website this coming Tuesday. I do want to offer my thanks to the speakers and the panelists for sharing their expertise and experiences. I would also like to thank our sponsors. We get support through multiple sources, and it's this support that makes things like access to our patient guide across this country possible, as well as supporting our mission and our advocacy work. So I would like to thank AstraZeneca, Bristol Myers Squibb, Gilead, EMD Serono, GlaxoSmithKline, Janssen, Merck, Pfizer, Sanofi, Novartis, Takeda, and Titan One. Thanks to each and every one of our sponsors for being part of this mission to make the lives of lung cancer patients and their caregivers better. So let's get started with our program. It's my privilege to introduce our first speaker. This is Dr. Stephanie Snow. She's a friend and colleague. She's a medical oncologist at the QEII Health Sciences Center in Halifax. She is our current president of Lung Cancer Canada. She's also a member of our medical advisory committee. And Stephanie is going to be speaking to us, discussing progress and the path forward in lung cancer care. Thank you so much, Stephanie.
Thank you, Roz, and welcome everybody to this 2024 Faces of Lung Cancer briefing. So I'm hoping to really set the context and start to talk a little bit what has inspired us this year for the Faces of Lung Cancer. Our major theme is that of equity. So what do we mean when we talk about equity? Our goal, our vision is that every Canadian patient with lung cancer will be able to receive equally efficacious treatment, diagnostics, and supports, regardless of who they are, regardless of where they live, and regardless of what type of cancer they have. Equity can take many different forms. We want to see equity in access to treatments. In our current healthcare system, that's not always the case, and sometimes where you live or what your healthcare insurance status is can make a very drastic difference in what treatments are accessible. We want to see equity in diagnostics. We are very excited that over the past few years, we're seeing establishment and rollout of pilot and real formal projects to do lung cancer screening. But as we're going to hear from Dr. Finley, there's still a lot more to be done. And we would like to see every Canadian patient that had an indication for lung cancer screening to be able to have that screening done in order to save lives. We would like to see further equity in terms of access to clinical trials. We're a very diverse country geographically, and some people live in large metropolitan centers with easy access to academic centers. Others live in more rural and remote areas in Canada. But we think that with innovative projects and new visions, we can actually see many more of our patients accessing cutting-edge research through clinical trials. And finally, support services. Having lung cancer can be hard physically. It can also have major impacts emotionally and in terms of socioeconomics. And so we would like to see equity in terms of our Canadian patients and their support and caregivers being able to access those very important psychosocial supports in order to make the journey as smooth as possible. There are many pre-existent variables that lead to inequity in treatment and access to care for lung cancer already in Canada. I briefly spoke about geography, rural versus urban, and we do know that in Canada, living in a rural area actually increases the risk of having lung cancer. We have already highlighted some difference between province and territories, and this is very important when it comes to drug coverage. There are some drugs that are approved in one province, but not another for lung cancer, and to us, that's not acceptable, that your postal code should determine what prescriptions you're given. We know that patients with lower socioeconomic status and lower educational levels are not only at higher risk of developing lung cancer, but they may have harder struggles in accessing care. It may be more difficult for them to take time off work or to pay gas to travel to a cancer center. They may struggle more so with health literacy and that important information that allows them to advocate for themselves. And finally, we're a very diverse country in terms of ethnic backgrounds and language. And we would like to be able to provide our education and our supports, not just in our two formal languages, French and English, but whatever language will best facilitate that for a patient. We also know there are particular groups, especially our Indigenous populations, who are not only at higher risk of developing lung cancer, but may be coming into the system with a prior history of trauma related to the healthcare system that can add to inequities. And we want to eliminate that so patients are receiving culturally relevant education and therapy and supports. So this leads me to a call to action. This is a call to action that we have stepped up to at Lung Cancer Canada. I would invite everyone to join us. There are many things that we can do to address these areas of inequity. We've done many partnerships, for instance, with our industry partners. We have projects where we're looking to do quality initiatives that will reduce inequities based on geography or your postal code. We also sponsor a lot of research, in part reflective of our partnerships with our industry partners. And we really try to focus our research efforts through our Lung Cancer Ambition Awards, our Jeffrey Ogre Awards, all of our awards, to really focus on making that level playing field, to look at improving quality of care and accessing therapy for all Canadians. Education is an important part of our mandate, not just for those who are living with lung cancer or their caregivers, but for other healthcare providers, for politicians, for anybody who's a key stakeholder to understand some of the issues, especially related to stigma and lung cancer, to try to eradicate that and the impact it has on providing equity for lung cancer patients. And finally, we serve as advocates, and we call you to join us for that. So when there is an area of inequity, be it access to the best diagnostics in one province or a CAT scan in another, or able to get therapy funded, or be it a screening test, we are there to advocate to the healthcare system and the powers that be in order to try to level that playing field. And so hopefully that set the stage well for the rest of our excellent program for today. And thank you all for having joined us.
Thank you so much, Dr. Snow. I hear your passion and your call to each and every one of us. So we'll be passing the baton now to one of my colleagues in Hamilton. It is my absolute pleasure to introduce Dr. Christian Finley. Dr. Finley is a thoracic surgeon at St. Joseph's Hospital here in Hamilton, but he has heard his call to action long ago. He is an expert lead for the Canadian Partnership Against Cancer. He is the clinical lead for the Ontario Lung Cancer Screening Program, and he is one of our members of the Lung Cancer Canada Medical Advisory Committee. Dr. Finley is going to be speaking to us about advances and challenges in screening for the early detection of lung cancer. So thank you, Dr. Finley.
Right. Thank you so much for having me. It's such an important topic to advocate for. Certainly, I think that we're at a generational opportunity for us to really bend that curve on lung cancer. And we've seen in so many publications lately that lung cancer is the fastest changing survival of any cancer. And I think that's in large part due to our ability to find it early and intervene at that time. And so I hope to speak a little bit about where we are and where we're going. For those of you that know me, you know that my grandfather was a thoracic surgeon. My father was my grandfather was a thoracic surgeon, my dad's a thoracic surgeon, and I'm a thoracic surgeon. And so I'm the only third generation thoracic surgeon that I know of. And interestingly, I have my operative reports from my grandfather and my father, and it's interesting to see how much has changed in those multiple generations, from my grandfather who operated only on a chest x-ray and had no better technology, to CT scans, to now we are pushing the envelopes of technology. I'm going to speak a bit about the background, really the evidence of the value of lung cancer screening, in particular from a survival and cost effectiveness standpoint, talk about how one designs a successful lung cancer screening program and to contextualize it, talking about Ontario, where we are in Canada in the future, all in 10 minutes. So it's going to be a whirlwind conversation. So hold on. Certainly from a lung cancer standpoint, lung cancer is responsible for the most deaths of cancer in the world. It's causes more death than prostate, breast, and colon combined. But we all know from this ecosystem of lung cancer advocates around the table here that lung cancer presents at a late stage, far later than other cancers. And while I think the world views lung cancer with a nihilistic or stigmatized lens, we all know that this is a fast changing environment that we're able to affect real change, and that we are seeing a 20% improvement in survival with lung cancer screening, and that generational opportunity is something that we need to take advantage of. And yet lung cancer receives a minuscule amount of funding, either by case or by mortality. Lung cancer is responsible for 25% of cancer deaths and gets 7.3% of the funding. It got $21 million in cancer funding in 2021, where breast cancer got 62, and yet lung cancer causes 4 times more mortality. And it's not to diminish breast cancer. It's obviously a deserving disease, but it speaks to the need for in our disease site. And so, really to answer that call to action from the World Health Organization and trying to reduce our mortalities by 30%, we plotted out, and we do need to increase screening, look at those inequities, and find ways to identify disease earlier and treat it with curative intent in a equitable way. We screen because we know that when we find it at early stage disease, the survival is much better. If somebody walks in with a stage 1 disease, it's obviously a very high chance of survival with no need for chemotherapy or other treatments, versus someone who's found at stage 3 or stage 4. But when people started in the 1970s, in my grandfather's era, they used just chest X-ray, and we know that chest X-ray is not adequate to identify disease at this stage where we can intervene upon it. And so moving forward through the decades, we had the NLST, which came forward and really showed a 20% reduction in mortality if we did low-dose CT scans in appropriate people. And then this was followed up with the Nelson trial, which showed the equivalent amount of survival improvement. So we know in multiple randomized trials that lung cancer screening is advantageous. And really it's getting the political will to get it off the ground. And I think that it's because it's stigmatized. If you came up with a pediatric disease where you had an intervention that would reduce mortality by 20%, there's no way that it wouldn't be across the board right now. So the Nelson trial was subtly different, but for the purposes of our conversation, really did show a 20% reduction in mortality for doing a yearly CT scan. It's cost effective. It's certainly as cost effective as breast cancer, if not more so. And then from a colon standpoint, it's equally cost effective. And so I think that there's no reason why we should not have this across the board in Canada. But certainly when we look at our landscape, it's universally available in British Columbia, which is fantastic. And I think has really reached the tipping point in the country. Ontario has it in 5 sites and is supposed to be in all the sites in the next 2 years. Nova Scotia has announced a province-wide program, and the rest of the provinces, with the help of various national institutions, are starting pilots. And I really think that it speaks to the need for groups like this to continue to push to get a program for everybody in all provinces in Canada. But to do effective screening, I think you just can't turn the lights on. I'm about as strong an advocate as you can find, and it took us 6 months here to get it up and running. You need to really engage across the board. We need to find those high-risk populations, navigate them through the system, make sure that the radiology is of sufficient quality, and then push that out the back end to people who can take those results and turn it into curative treatments. Nelson and the NLST just used smoking and age. They just said, if you'd smoked more than 30 years and you're 55 to 74, in you come. We've realized over the years that you can do better than that by looking at people's individual risk, by their family history, by their history of COPD, and you can do a better job of identifying people who are particularly at risk using the PLCO model, amongst others, and really bringing those people in that you can show superior results. And certainly BC has done that, Ontario's done that, and most contemporary programs are doing that. Smoking cessation is obviously fundamental. We need to help people to stop their addiction, and that helps with the cost effectiveness, but also I think reducing secondary diseases. But that system has to be done programmatically. It can't sort of be done off the cuff, and it's hard work. It's tough work, but it's something that we just need to remember to do. And then really when it comes to that diagnosis, it needs to push off the back end. There are some volume issues, being able to take the 3% of patients that are going to have a positive scan and evaluate them in a reasonable time frame is also important. And so it speaks to the utility of diagnostic assessment pathways or the equivalent across the country that are constantly under threat of underfunding. And so it speaks to the need for advocacy there as well. In Ontario, we have the 5 sites that I talked about, and they represent obviously important and diverse sites. But I think the important one to note is Ottawa, which I think was the first to have spoke sites, so putting care closer to home, which is a real barrier to people. We know that geography as well as income are real barriers to people getting involved in this. And so I think these spoke sites are helpful. BC's got a great model as well, which is centrally run as well. And most of the provinces are looking at that. When we look at Ontario, we were able to recruit 8,000 people in our pilot phase and really get about 4,400 through to their scans. And really we're superior to the NLST or the Nelson, which is what we were anticipating, by using that 2-step process of finding people with a potentially lower tobacco smoke exposure, but looking at those other factors. We were able to find low stage disease, which is what we would anticipate. And those are the people that you can cure, the people at the stage 1. And that you find things by accident. And I think that when we're talking about, challenges to lung cancer screening, if you don't have a tight radiology, if you don't have people that are reading in a systematic way, these are the things that break the system, which is actionable incidental findings. So when you find out that people have calcification of their vessels, other findings that need to be worked up and dealt with. But if they're overcalling or undercalling it, that can result in downstream consequences and loss of effectiveness. I think that the Ottawa model that we have had in Ontario and that BC's centralized model allows us to deliver care closer to home, and that's a big deal. I think that those barriers that people face from access to care, from geography, as well as wealth, can be mitigated by bringing things as close as we can to them. But we can't discount, that this is a lot of people, and that's the big fear that people talk about, is the cost of it, and then also overrunning the system. But in Ontario, we found it only represented 3% of the scans in those regions, and because they're non-contrast scans, they could be done after hours, and it didn't break the system, which is good to see. It didn't change the time for anybody else to get their scans. So what does the future hold for this? Well, I think that we're in an era of ever-evolving technologies, and artificial intelligence obviously being the one that's most at people's fingertips, and it's a game changer. I really think that we're going to see, hopefully, our radiology colleagues put out of work with AI being able to read these in a more systematic way. I think the individual risks that people face, both their screen intervals, how their personal risk changes, and their genetics are going to affect our understanding of this disease, our recruitment, and our ability to get past the stigma. I think that's where it's a different era now. So I think that we need to face that. So I think in conclusion, hopefully and almost certainly coming to many sites in Canada, lung cancer screening, I think there's questions about how to deliver it and implementation, but I do think that this is a generational opportunity. So I think that we need to rise to the challenge, and I don't think that there'll be another change in my lifetime or my father's or my grandfather's lifetime that could affect the survival of lung cancer quite like we have now. So thank you for listening to me.
Oh, thank you, Dr. Finley. I'm going to quickly sneak in one question that came in on the Q&A. And the question was, is that 2 to 3% rate of patients with suspicious lung nodules to warrant screening similar to other imaging screening programs like mammograms?
Oh, interesting.
Do we have a sense?
Yeah, I don't think I can answer that accurately. That's the 3% rate that we're finding is with good radiology reads called lung rad, so it's systematic. And I don't, and we saw that off at what's called a 4, which is 2 to 3%. And I don't know what the positive screen rate for breast rads, which would be B rads, or some of the other ones, or thyroids has the same thing, T rads, would be for that disease site. But it's an acceptable amount. That half answers your question.
Oh, thank you so much, Dr. Finley. I want to make 2 quick shout outs at this point. If you have found this topic fascinating, we are actually doing our first advocacy forum a week today on November 14th, and you can hear Dr. Finley as well as representation from across the country speaking about lung cancer screening. I also want to take a minute to have some motherly Canadian pride here. So Dr. Stephen Lamb, who's one of our panelists today, has actually been a global leader in lung cancer screening, and he was one of the senior investigators on a trial that was presented at the World Congress of Lung Cancer, which looked at something called the PAN-CAN review of these scans. That actually was able to reduce the number of scans and able to find just as many, if not more, lung cancers using a new way to look at these scans. And we also have to have great pride in Dr. Martin Tamamagi, who has refined how we can do and include more patients who are going to get access to screening. So we've got a lot of things to be proud of. I also have to acknowledge my first of what I'm sure will be many moderator snafus. I missed one of our sponsors when I was going through that list. I'll blame it on my 50-year-old eyeballs. So I'd just like to quickly thank Amgen, who is also one of our key partners and sponsors over the year. So let's move on to our next speaker. Again, honor and a privilege to get to introduce Dr. David Stewart. He's a medical oncologist at the Ottawa Hospital and professor there. He's a member of our medical advisory committee, and he's going to talk about something that's near and dear to my heart, which is new and emerging treatments, and really work on accelerating access to our Canadian patients. So thank you so much, Dr. Stewart.
Okay, well, thank you for the opportunity to participate, and thank you to Lung Cancer Canada for all it does to make it easier for me to look after my patients. So to put things in perspective, 48 years ago, when I began my medical oncology training, the treatment regimens for metastatic non-small cell lung cancer, the response rate would be a bit less than 20%, with a median duration of response of maybe 5 to 6 months. And then in the late 1970s, a wondrous new drug came along called cisplatin that worked against a broader range of types of cancer than any other drug that had ever come along before that. And it became one of the mainstays of treatment of lung cancer. And then over the next 20 years, several more drugs came along, like Vindicin and then Vinorelbine, etoposide, paclitaxel, docetaxel, gemcitabine, pemetrexate. And all these led to improved ability for us to control lung cancers and give patients improvement in symptoms and prolongation of life expectancy. In the late 1990s, work began on targeted therapies with things like gefitinib. And the feeling at the time was that if we were lucky, these drugs might slow down the growth of tumors that overexpressed the target, like epidermal growth factor receptor in the case of gefitinib. And to our great surprise, something happened that was not supposed to happen. And that was about 5% of patients had dramatic tumor regression with marked improvement in symptoms, often lasting for 1 or 2 years or more. And this was not supposed to happen. But then in 2004, the epidermal growth factor receptor mutation was found, and the link of that to the efficacy of gefitinib and erlotinib, and the rest is history. With that, lung cancer, adenocarcinoma of the lung became the poster child for so-called targeted therapies or personalized medicine in cancer, with subsequently a large number of different mutations being discovered for which therapies rapidly became available. So these radically changed the way that we do things. Then the next big advance was in 2014, 2015, with publications and presentations on the immune checkpoint inhibitors. When I began my medical oncology training in the mid-1970s, immunotherapy was about to cure everything. So a tremendous amount of hype and hyperbole. So my message to residents was that immunotherapy has been about to cure cancer for the past 50 years. And I did not think it would ever do anything at all. But I'm always delighted when I'm wrong. And so when I saw the benefit of these immune checkpoint inhibitors, so they're the greatest advance since cisplatin, because of the range of different tumors across which they will work. So there's a lot more work being done on immune checkpoint inhibitors. So there are about 13 different immune checkpoints all together, and these protect your normal cells from your immune system. But we can now inhibit 2 of them. So CTLA-4 with ipilimumab, and the PD-1, PD-L1 system with a variety of different drugs such as pembrolizumab and nivolumab and atezolizumab and durvalumab, drugs like that. But so far, the only 2 that are really useful are just the inhibition of PD-1, PD-L1, and to a lesser extent in lung cancer, the CTLA-4. And we don't know whether or not the inhibition of the other 11 immune checkpoints, whether we'll gain anything from that or not yet. But a lot of research underway. The reason we might not, twofold. One is that the cancer cells may not be protecting themselves from the immune system through those other, or the other thing is that we may have just got lucky with the PD-1, PD-L1 in that they may be most important in protecting the normal cells early in life. And so if you turn it off later in life, you're less likely to have a major adverse effect. Because we know, for example, that ipilimumab against CTLA-4, there is more toxicity, so that we don't yet know what's going to happen with the other ones. Then the other thing that's come along as well is the whole field of antibody drug conjugates. So adding new drugs to monoclonal antibodies. Again, there's some early promise in lung cancer, and we expect that there's going to be more there. And also bispecific monoclonal antibodies, ones like amivantamab that target both EGFR and MET and have activity against and various some very specific areas, are bispecific T cell engagers that bind to a tumor cell and also to a tumor cell to bring the immune system in close to the tumor. So all of these do have promise and some early indications that they could be of some benefit. And then there's a field of vaccines. So the two major reasons that cancer escapes the immune system, one, as I said, is it has defenses like the PD-1, PD-L1 system. The other is about half of all cancer cells, there's a defect of what's called the antigen presenting machinery. So that in all of our cells, we're constantly breaking down protein, converted to peptides that is then carried to the cell surface on what's called the antigen presenting machinery to present to the immune system. And if it's recognized as something new and foreign, then an immune reaction is mounted against it. T cells are brought in to kill the cells that express that because it's abnormal. If there's nothing abnormal, then nothing else is done. But about half of all cancer cells or cancers, there's a defect of this antigen presenting machinery. So if we can present those antigens in a new and different way, then that might permit the immune system to activate it. And again, a huge step forward was the mRNA vaccines for COVID that showed us that this technology can be used. And so right now there's studies that are underway where a whole bunch of different antigens that are common in cancers are expressed in one of these vaccines. But in the future, it will be taking a patient's individual tumor, looking for antigens or proteins that are new, that are different from their normal cells, to rapidly make a vaccine that will be that will work for them, so that the immune system never got the message from the cancer cell itself that there was something abnormal, but will be able to sneak in through the back door. So there's a real potential that this could be very, very important. Although again, there's lots of things being tried in immunotherapy that haven't worked. So we have to just keep our eye on the data, but some real potential there. Now, as far as the research, so things have changed radically in the 48 years since I entered medical oncology training. And so that patients that used to live just a few months, now living 4, 5, 6, 7, 8 years or longer with metastatic disease. So this is a fantastic problem to have. But my mentor, the head of our department, when I was doing my training at MD Anderson, Emil J. Freireich, had Freireich's laws. And one of Freireich's laws was the only people who come close to predicting the future, are the science fiction writers, and they always underpredict rather than overpredicting. So if you can imagine it, then it can be done. So that's where the new treatments are going to go. If we can imagine it, then there's a potential in the future that it can be done. Another one of his laws was always be prepared for success. And we are not prepared for success. So now my clinics are overflowing with patients coming back year after year. And this is a fantastic problem to have, but we're not prepared for it. And also all the new drugs that are so effective, but also cost so much. We are not prepared for this. So we have to bear this in mind and come up with new paradigms to deal with this. With respect to the clinical research, back in the 1960s, it took an average of 8 years to bring a new drug from discovery to approval. By the early 2000s, that had risen to 12 to 15 years. And that was all because of increased regulatory stringency. And those regulations are there for a very good reason. Every one of those regulations is there because of a problem, but there's been no attempt to really look at the regulations to try to figure out how to do it faster, more effectively, and at lower cost. But COVID and the AIDS treatments told us we can do it. All we have to do is decide that things must be faster, and we can make it faster. We just have to make this a priority. The other thing that all that regulation did, it radically increased the cost of developing a new drug from an average of $4 million back in the 1960s to $2.9 billion by the year 2013, and it's risen rapidly since then. So the problem with this large cost is if it costs a lot to develop a new drug, then there's less resource to develop others. So these very large costs directly slow progress by reducing the number of drugs that we can actually look at. The other thing that they do, if that costs a lot to get a drug to market, then those costs have to be recouped later on once the drug is marketed, and also only fewer than 10% of cancer drugs that enter clinical trials ever make it to approval. So all the costs of those failures also have to be recouped from the few that succeed. So that is one of the major driving factors in the very rapidly rising cost of new drugs. And the other one, of course, is personalization. Being able to identify who will benefit means that we now only treat the 10% of the patients that are benefit, and that's fantastic. But the entire cost of new drug development has to be recouped from that 10%. So those are two major factors that are driving very high drug prices. And the very high drug prices are the number one threat that we have to progress, because if the prices are very high, then buyers will stop buying them. We already know in Canada that we're way behind most of our peer countries in funding for effective new cancer drugs. We're way behind. And if all countries start doing that, and companies can no longer sell these new drugs for which they've spent a fortune, then the investment will dry up and there will be no more investment in new drug development. So this is the single biggest threat to progress. So we've got to figure out how to fix this. And there are many, many different opportunities to make clinical research much, much faster, much less expensive, much more cost effective, to at the same time get effective new drugs to patients rapidly, so there are fewer lives lost because of delays in access. At the same time, bring down the cost of these drugs. So that's what we have to work on. Many ways to do it. We've published extensively on this, and all we have to do, we just have to make this a priority.
Oh, that segue couldn't be more perfect. Thank you, Dr. Stewart. And I do need to give a shout out to Dr. Stewart. If you're interested in reading more about this, he didn't ask me, but he does have a book that he's published on this very topic. So if you're interested in reading more in depth, I think you can find it on Amazon if I'm not incorrect. And there's been several publications in the literature that he has led talking about the lives lost and the maze that is the path towards access for cancer patients. Well, I'm the next speaker up to bat. And as I said, Dr. Stewart segued very nicely for me in that I'm going to talk about clinical trials. And without clinical trials, we wouldn't have any of these new treatment opportunities. So I'm going to give you a bit of an overview of clinical trials and how we can potentially increase the impact to our Canadian patients. See. Just trying to figure out how, maybe if you, oh, here we go. Perfect. Advancing slide. So what are clinical trials and why are they important? And I will tell you, I have paraphrased this from that Shiny New Lung Cancer Canada website. So a clinical trial is a carefully controlled way to research the effectiveness and safety of new treatments. Clinical trials are conducted under close supervision of doctors and other research professionals, and they are overseen by multiple groups. The first of which is Health Canada. Health Canada oversees all interventional research. And so that's a really important aspect. We have a wonderful regulatory organization in Health Canada overseeing the safety of patients. But secondarily, on an individual site-by-site level, there is a group called a Research Ethics Board. This is a completely independent group of research professionals that review each and every protocol to make sure that the safety of patients is being held to the utmost regard. And without clinical trials, we would not have new technology or therapies to treat lung cancer. So one of the first barriers is patients have to realize that clinical trials exist. I was giving a presentation to the Patient and Family Advisory Committee of my own institution, and I was talking about how important clinical trials are. And I was shocked when one of our patient and family advisors asked a question in quite candor and said, I don't understand. I thought clinical trials was only for people who had no other options and were at the end of the road. Why should the average cancer patient be interested in knowing anything about clinical trials? And I took a step back because this is a person who is an incredibly well-educated person, and that was their interpretation of where clinical trials should fit into a cancer patient's journey is only when there's no other options and there's no hope, quote unquote, left. And that is absolutely far from the case. We do clinical trials in screening, where this is not even a person who is yet to know they have cancer. We do clinical trials in preoperative treatments, in surgery. We do clinical trials, obviously, in the locally advanced and metastatic setting. And so there is potentially a clinical trial for any person along their journey with lung cancer. But how are you going to know that these clinical trials exist? We know that the healthcare system has a lot of burden on it, and people are struggling to even get access to a family physician. The number of patients that each individual oncologist are seeing is growing rapidly, so the amount of time that is able to be spent with individual patients is becoming less and less. So how does a patient advocate for themselves and sort out if there's a clinical trial that might be useful to them? Here, I've given a snapshot of some of the resources that exist out there to help patients advocate for themselves. One is a website through a group called the Canadian Cancer Clinical Trials Network, and they actually have a clinical trials finder on their website, and I'll show you what that looks like. There's a website that any person from the general public can look at through the Canadian Cancer Trials Group. That's our largest academic collaboration of cancer trials across this country. You can actually search the Health Canada website. There's the larger clinicaltrials.gov website that covers clinical trials across the planet. And there's also another website called Canadian Cancer Trials. And all of these can be found on the Lung Cancer Canada website, so you're not having to search for them individually. If I show you some of the Canadian grown ones, this is that precision oncology trial finder that's on the CCCTN, or the Canadian Clinical Cancer Trials Network website. And you can actually put in your province, your diagnosis, and even if you know your biomarker, and it can tell you where clinical trials might be available for an indication for you. Now, if that level of technology is above and beyond your scope, we actually have humans. So I think this was one of the best ways that money was spent through the CCCTN group. And they actually have a clinical trials navigator that works out of one of the Ontario sites. But this person will actually help try to identify a clinical trial for anyone who reaches out to them. And so I've included their website below. We realize that technology is not everybody's strong suit. And so sometimes having that personal touch of having a trials navigator can be truly impactful. Now, one of the other things that's really important about clinical trials is historically, this has been done at the level of the physician. And we sit together and we'll talk about ideas that we think might have an impact. And we build these clinical trials based on experience, based on training. But it's only been recently where we've actually brought patients into the mix and have looked for their feedback on what the feasibility is of conducting this clinical trial. What do they think about the different tests that are involved in this? What do they think about the question we're asking and whether or not it's relevant to them? And so patient-centered designs are critically important. If we open up clinical trials that don't carry meaning to patients, we're not going to get the question answered, and we should be putting our effort forth into questions that are impactful for patients. So one of the ways that we have tried to engage in this is through something called patient and public involvement. The concept of patient and public involvement is ensuring that ideas, concerns, and wishes of the general public are incorporated into the design and conduct of trials. And this happens now at all levels of research. It happens at the grant level, it happens in the clinical design level, as well as now in the portfolio creation. So different groups are looking for patient feedback on what trials we take on in different jurisdictions. So if this is something that's of interest to you, we at Lung Cancer Canada get requests all the time from Canadian researchers looking for patients who might be interested in providing feedback on their grant proposals. And there may be other opportunities to become involved. So please feel free to reach out to us. We also have spoken today about patient access. This is a snapshot from the Canadian Cancer Trials Group that's looking at the number of participants across the different provinces who have been able to participate in trials. You can see things are heavily weighted in our two most populous provinces, Quebec and Ontario, but there has been access to clinical trials across the country, but you can see participation starts to dwindle the more rural the population is. And that has been something that we have seen, and we've recognized that it's something that we have to tackle. And one way that we have attempted to tackle this is through a project called the Canadian Remote Access Framework for Clinical Trials, or it's called the CRAFT project. And this is looking at how we can create hubs and spokes to allow cancer clinical trials treatment closer to home for our patients. And there have been pilot projects that have run out of BC and pilot projects that have run out of Ontario, and pilot projects that have run out of the Atlantic provinces. And we're seeing more and more of this becoming part of our world. I think many of us will complain about things that happened through the pandemic. But one of the things that was good from the pandemic is things like this. I think everybody has now heard of Zoom. We have figured out ways to connect in ways that we were never able to connect before. And we're taking that technology and making it part of how we conduct clinical trials so that we can have clinical trials in the far north and as far east and west as we can go. Now, one of the other things that's very important is research infrastructure. Research infrastructure is key to our success. When we think about the village it takes to conduct a clinical trial, there are so many different parts of the healthcare system in which we encounter. We have to encounter with our contracts group. We have confidentiality agreements because this is often proprietary information. We have finance officers, contacts with radiation, surgery, pharmacy, pathology, sometimes inpatient, outpatient, radiology. These are all key contacts that we need to have to make clinical trials run. But one of the other resources we need are physicians who are interested. So it's very difficult to get a patient connected to a clinical trial if their treating physician is not someone who's comfortable. And this is a body of work that was done by one of my former trainees, Dr. Michaela Febraro. She's now one of the physicians up in Sault Ste. Marie. And we just looked at how comfortable are our Canadian trainees in oncology at talking about clinical trials to their patients. And while they may be comfortable discussing a clinical trial, then that actual work of being an investigator and offering clinical trials treatment drops down to only 25% of our trainees being comfortable. We need to do better as a Canadian society if we're going to be raising oncologists. So just in summary today, clinical trials are key to forward progress in the treatment of lung cancer, but we need our patients and families as key partners in making trials a success. We need to increase public awareness that this is a critical need, and we need to make trials more accessible. So we'll continue on here, and we've actually got a wonderful panel now. So I'm going to introduce Dr. Stephen Lamb. He's one of our panelists. He's a respirologist at BC Cancer, and he's a professor at the University of British Columbia. He's also a member of our Lung Cancer Canada Medical Advisory Committee, and he is going to join his other colleague, Dr. Jeffrey Liu. Dr. Liu is a professor of oncology at the Princess Margaret and the University of Toronto here in Ontario. He's a senior scientist at the Princess Margaret Cancer Centre. He is also an active member of our Lung Cancer Canada Medical Advisory Committee. And we're going to go through a few questions on building hope for the future and recent advances in lung cancer research. So I just want to thank Dr. Liu and Dr. Lamb for their participation today. So if it's okay, I'll start with maybe the first question. So Dr. Lamb, as I mentioned, you've been incredibly impactful in advancing our early detection of lung cancer. Could you spend a moment or two and talk about new screening methods, including using things like peripheral blood or even people's expired air, and how that might be helpful in our screening endeavors?
Yeah, so thank you for having me. Many of us may not realize that lung cancer affects people who have never smoked. So there's an increasing number and proportion of people who have never smoked or smoked lightly. They may not be eligible for screening. So in Canada, we are actually doing research into how to identify people who are at high risk of lung cancer who have never smoked or have a light smoking history. So one approach is that we have a risk modeling team consisting of Martin Temamagi, Rafael Baser, and Trevor Dummer. They use large population data in Canada, such as the Next Generation Project, in combination with other large data set in the US, UK, and also in Taiwan, to develop the next generation risk prediction model that will encompass environmental exposure. So in parallel, we have Regine Hong and Jeff Liu, who are doing a very exciting work and using a blood test to identify people with high risk for lung cancer. And we have a little spot or nodule on the CT scan, whether these spots are cancerous or not. This test can be done with even a drop of blood, so can be very simple to apply. We're also working, my colleague Renelle Meyer is also working on a breath test to collect the breath sample to do similar thing. So ultimately, we try to look at how this simple point of care test like a breath test or blood test can be applied to early detection and also determining whether a spot is cancerous or not. And we can compare the incremental value using the risk prediction models that we develop in Canada and also look at the cost implication before we, that's how we can be guided to implement this test in Canada.
No, that's fantastic, Dr. Lam. And I know I just got this question yesterday from one of the children of one of my lung cancer patients. And there's many people who are out there who are interested in, what happens to our never smokers. So I'm really glad to hear that we've got research that's homegrown, that's looking at how we can potentially make lung cancer screening accessible to the wider population. I've got another question for you. I bet everybody in this audience has heard of ChatGPT, and there's lots of buzz out there about artificial intelligence, and it's not just taking over the world like the Terminator. Have you seen any role for artificial intelligence in your work in lung cancer screening?
Yes, I think artificial intelligence plays a very important role. So, for example, in the British Columbia lung cancer screening program, we use an AI-driven computer vision diagnostic tool to assist the radiologist to interpret CT scan. So these tools can automatically find nodules or spots of this in the CT scan and measure the size or volume and to determine the malignancy risk to help us to guide management decision. But which is even more exciting is this kind of technology can potentially look at a single CT scan to determine whether someone is at high risk for lung cancer. So for example, in the screening scenario, someone may have a biologically aggressive cancer. We may have to screen more frequently, while people are at lower risk for lung cancer, we can screen a longer interval. So this technology has significant implication in terms of access to care, resource utilization, and also cost. So these are exciting times that we have.
I think it's absolutely fantastic because it honestly evens the playing field, especially in a country like Canada, where people are spread across the nation and they may not have local radiologists who have experience in this. And so I think this is going to make it such that it is truly going to be highly impactful in the screening world. So thank you so much, Dr. Lam. I'm going to jump over to your partner in crime here, Dr. Liu. Dr. Liu, you're known globally for your work in precision oncology, and you have been at the forefront of many targeted therapy trials that are impacting people all over the planet. Now, in the past, I've heard you talk about precision medicine as truly a quantum leap in lung cancer treatment. Can you tell us a little bit about genetic profiling of tumors and how it's impacted your patient practice?
Oh, yes. So when I started several decades ago, I would never have thought that I'd be talking about patients living for years and years and years with metastatic disease. Obviously, we would love to be able to diagnose all of these patients at the earliest of stages, but we know that there's going to be a proportion of patients that will be diagnosed at later stages. And in the past, we would be saying things like, well, you have a limited number of time left, measured often in months, and that's dramatically changed. Like in for example, in June of this year, there's data that came out showing that using the first drug, and there are other drugs coming through, and there's also chemotherapy afterwards and other types of treatment, but using just the first drug for a particular subgroup of patients known as ALK positive patients, that 60% of individuals are still on that drug at 5 years. And that's incredible. So we haven't even gotten to the 50% mark yet. And obviously you have to be alive in order to be taking this drug. So we know that many of these people will be living, for many, many years with this. And that's really exciting. And then the next thing that happened was just a couple of months ago in September at the European Society of Medical Oncology a meeting, a drug came out that's still in development right now, and we're very lucky in Toronto, for instance, to actually have that trial open. That a drug called taletrectinib for ROS1 mutated patients, they actually had a 46-month median progression-free survival, which means half of the people were still on the drug close to 4 years. Right. So that's before there are other drugs after that. And there's also chemotherapy and other treatments. But this is incredible, and although we'd love to be able to at some point say that we're talking about more than a decade, right? This is a substantial advance to when I came into the field, and we were talking about maybe a year. At best for many of our patients. So that gives you some of the examples. If we can identify the right mutation and match it with the right drugs, the drugs get developed along with the biomarker associated with it, and then these possibilities are actually there. So we're hoping to see more and more of these success stories. And as we get to the next generation of drugs, stretching that period of time longer and longer for our patients.
Absolutely fantastic. We are going to turn lung cancer into a chronic disease, and then we're just going to try to eradicate it altogether. So Dr. Stewart spoke very crisply about his memories of immunotherapy coming and the hope that it was in the beginning of his career, and now the reality that it is in our world. Can you talk about the advancements with immunotherapy? And we often use immunotherapy in people who don't have these driver mutations. What's been your experience, and what do you think about the landscape for these people who don't have driver mutations?
I didn't come in quite as long ago as Dr. Stewart, but when I came on, immunotherapy was just peaking, interest, and then it fell again. So it's done this maybe 3 times now, and and I also had bet that it would never succeed. So being proven wrong has been a very, very positive thing. This is what I've got to say about this. Who would have thought that immunotherapy is now the basis of treatment in non-targetable non-small cell lung cancer? Who would have thought that now, instead of thinking chemotherapy maybe plus something else, we're starting off with immunotherapy first and then plus or minus chemotherapy? Who would have thought in this case? And who would have thought that we are now marking, in some cases, at 5 years, in some subgroups of patients at 5 years, close to a third of those patients are still alive after having started with treatment with immunotherapy or immunotherapy with chemotherapy. So this is remarkable, right? We would never have thought of using the word cure or anything like that, and I wouldn't dare use that. But on the other hand, having up to a third of patients in some of these subgroups living to 5 years and beyond is just remarkable as well. So there's massive promise moving forward. We just have to figure out which patients match with which drugs, right? And then figure out which ones that we don't make it to that point, and develop new drugs. in this forum. So that's the exciting part and the hope that we have moving forward.
And it brings me so much joy that, all of this work, started in the stage 4 setting, but right now the incredible progress is actually in the early stage, in the curative intent stage. And who would have thought now that we would have immunotherapy and chemotherapy for our patients, and now targeted therapies in the post-surgical setting. And I think that that's just going to continue to evolve. So it absolutely is incredible, sort of triple threat of screening and now therapies in the curative intent space, and then all of these advances with better and more refined drugs with better targeting of the target, but yet fewer toxicities to allow for people to stay on treatments for 4 and 5 years. I might jump into the last question for this panel then. So looking ahead, I hear optimism from you both, and maybe that's a character trait of oncologists in general, is we are eternal optimists. I'm going to give you each a minute to tell us, what do you think are the things they're going to focus that next 10 years? So maybe I'll start with Dr. Lam. Where should we be going?
So I think a combination approach of early detection and treatment, I think will bring about the best improvement in lung cancer outcome in Canada. So by detecting, treating cancer, the chance of cure is higher. And also this new exciting treatment that Dr. Liu just mentioned, I think we'll see more and more improvement in the next 10 years. So I'm very hopeful the lung cancer patients will be much better in the next 10 years.
And how about you, Dr. Liu? What do you see in the next 10 years?
This is my hope. And again, I'm an eternal optimist when it comes to this. My hope is the fact that we have been doing screening in breast cancer and in colorectal cancer across the board, right? Just based on age, right? And so forth. But in lung cancer, we're now only screening people who are heavy smokers. And the majority of the patients I see are those who would never have been able to be screened in the first place. They just never smoked enough to fall into that category. So my hope is that what we'll see in the next 10 years are tools such as the breath testing or the blood testing or some other way to actually screen everybody. And then maybe diagnose these individuals at an earlier stage, and then be able to use the precision medicines and also the immunotherapies to actually improve cure rates. So we're not just talking about just control of disease, but massively improving cure rates by early detection across everybody, not just those who are heavy smokers. And at the same time, utilize all of our new-founded treatments at the earlier stage. And we can finally use the word cure, which is what I've been really, really hoping to use for our patients moving forward.
Well, Dr. Molosky and I wrote a paper about this concept of cure, but one of my more exciting things is I got to chair an ASCO and International Association for Lung Cancer panel at the World Congress of Lung Cancer on survivorship in lung cancer. And we talked about all sorts of things about watching for people's cardiovascular health and how do we introduce exercise to improve people's outcomes. And I just think it's fantastic that we even have to talk about these things. It's so wonderful. So I want to thank both Dr. Lam and Dr. Liu, both for the dedication that they have made to lung cancer in their careers and very illustrious careers that they have been and will continue to be. So thank you for sharing your vision for us today. Okay, so you wouldn't think that we could outdo that panel, but we are about to outdo that panel. And so the next group that I am thrilled to introduce is actually our patient and caregiver panel. So we've entitled this section of our Faces of Lung Cancer briefing, Voices of Hope and Resilience. So we have multiple speakers today, so I'll introduce them as we go. First, we've got Tanya Bossy. Tanya is a caregiver advocate. She is pictured here with Mike Bossy, who many of you will know was a dedicated hockey player, and they have made it their mission to have the knowledge about lung cancer increase and want to truly improve the outcomes of people who are living with lung cancer. Next, we've got our physician representation. This is my partner in crime. This is Dr. Kevin Zhao. He and I co-lead together the Medical Advisory Committee for Lung Cancer Canada. I'd like to give a quick shout out to him. He's actually made it possible for us to have a voice on the Quebec landscape with regards to drug approvals and implementation. Before it was not so easy, and Kevin has laid a path for the Lung Cancer Canada voice to be heard, not only at the Canadian Drug Agency, but also at INES. So he's a medical oncologist at the Hôpital, I'm never going to say this right, Sacré-Cœur. He is an adjunct professor at the University of Montreal, and he is one of our panel speakers. Next, we have got Bev Marr. She's one of our patient advocates, and Ron Foreman. He's a caregiver advocate. I was actually going to ask you to guess who was the patient, but I gave it away with their introduction. So looking forward to hear from Bev and Ron. And then next we've got Katie. Katie Hulen is also a patient advocate. And again, you might not guess that Katie is a woman who is managing a life with lung cancer, but that is the case, and she'll be speaking about the transformative power of precision medicine. Okay, so we're going to get ourselves going here. So why don't we get rid of the slides, guys, so we can see the faces here. So why don't we start by hearing from our different panelists. We'll go around, and I'm going to ask for folks to speak a little bit about a pivotal moment from their journey, whether that might have been as a patient, a caregiver, or a clinician. So why don't we start with Tanya? Tanya, why don't you tell us a little bit about your story and your journey? Oh, you're muted still, Tanya. Can we get Tanya unmuted?
I'm sorry.
Perfect, we can hear you now.
So my journey was caring for my father, who was diagnosed in October of 2021. And unfortunately, it was a short journey because my father passed away. But so I cared for him, and it was quite hard. But I guess we'll get to talk about specific questions later. I'm not sure if I...
So maybe, and your co-panelist for this section is Dr. Zhao. So our question to the two of you is, how can patients, caregivers, and clinicians work more effectively together in that decision-making and treatment planning? So what did you see in that patient, caregiver, and physician partnership? And what do you find has been the role?
Well, I think with Dr. Zhao, the role of the doctor is to tell the truth. And I think that was hard for us because his truth was not what we wanted to believe. But I think it is important that the doctors are the transparency, that we know what we're getting into, and that we know what the outcome is, so we can better prepare. And the grieving of the decisions we have to take, but are not our decisions as well. So in the journey, we had to respect my dad's, what he wanted was not always the same as what we wanted. So that could be quite difficult. But I think the communication with the doctors is very, very important.
Now, Dr. Zhao, shared decision-making has been a buzzword lately. Why don't you tell us how you see the physician role?
It's interesting. I think this question is super important, and I think I wish there were more physicians on this call, just because I think it's something that we need to reevaluate, just our model of how we see patients and diseases. And I think and Dr. Lam, Dr. Stewart, and Dr. Liu, who are also on the call, probably know and have had the same experience. It's just how we've been taught as physicians to treat the patient with a certain disease, and we have all these wonderful treatments. But the issue I think that we tend to forget is that the disease doesn't just touch the patient, it touches more than just the patient, it touches their families, their friends, their support group. And sometimes we forget when we're questioning patients, talking about treatments and side effects, is just the stuff that happens once they leave our office. And I think when we talk to patients, we sort of tend to forget the bigger scope of what's going on. And I think that's where communicating is such an important thing, but not just to the patients, but to the caregivers as well. Sometimes when I have patients in my office, I always tend to look at their caregivers to give me the sort of additional information that is sort of lacking. And the prime example with Tanya's dad is that he was very tough on his body when it comes to pain. And I would always look over, either to his wife or to Tanya to give me sort of cues as to what was really going on at home. And I think it's something that I value more now than before, just how important it is to include, family members, because they're also going through a lot of stuff. And I think it's very important to not lose sight of that. Treatment of patients is not just treating the body, but it's also treating the mind and treating the support group, because they're just as important, if not more. And so I think if there's one message I would give to everybody, it's just that it's important to share your voices. And if you're a patient or caregiver, don't hesitate to tell me or any of my colleagues that there's stuff going on, because I think what you're saying speaks more volumes than what any scan or blood test can show me.
It's easy to throw on some mascara and a brush through your hair and make yourself look shiny for that 10 minutes, and it doesn't tell the tale of what's going on behind the scenes. I completely agree with you, Dr. Zhao. I'm going to move over to one of our caregivers, and a good segue there. So Ron, you obviously have played the role of caregiver. What support systems have been most beneficial in your experience, and what can we do to create networks for patients and caregivers so they don't feel so alone?
Thank you for the question, Rosalyn. Bev and I went in the beginning to where maybe most people would go, and that is to family and friends. We're very fortunate to have siblings nearby and children and grandchildren, and they've been a huge source of support. I know some people may not have that, and I can imagine it would be much more difficult. In that case, they can certainly start at Lung Cancer Canada with the huge amount of resources for newly diagnosed patients and caregivers. Let me just say that my role as a caregiver has not been that difficult to this point, because Bev has been on osimertinib for 5 years, and we're basically leading a relatively normal life. The only thing that's changed is Bev is totally dedicated to her role as a patient advocate. And so in order for me to support her as a caregiver, I try and pick up as many of the other responsibilities we have to free her up to do her advocacy. And one of those, of course, is tech support, to make sure that her her phones and computers and so forth are always working. Which reminds me, I got to fix that otter.
I was jealous because Bev's got better tech than I've got, it seems.
You'll stop me when my time is up. I'll just go quickly here. Peer support, connecting with other caregivers. I haven't done that specifically yet, except that Bev has volunteered with others to organize the Evening of Hope. And so we have sort of an informal committee there of patients and caregivers. And while we're working on this Evening of Hope, we're building some relationships that will continue on as a caregiver and patient support. Another thing that Bev and I have done is we do a lot of exercise. We do yoga, meditation. This has been very helpful. It's very important for patients and caregivers to look after their health, make sure their diet and sleep and exercise. I'm not sure of any studies, but I think I've heard, and Rosalyn, you made a presentation in San Diego about how important exercise is in this whole process. So that's what we've tried to do.
Oh, fantastic. Well, thank you, Ron. Next, I'm going to move on to our two patients on the panel, Bev and Katie. So I've got a few different questions I'm going to pose in your direction. So first, what unique insights can each of you provide into the importance of advocacy for lung cancer awareness? And then second, how can your individual experiences shape the narrative around lung cancer, especially in reducing stigma? Maybe Bev, we'll start with you, and then I'll pop over to Katie.
Okay, and Rosalyn, thank you for the question. Well, I think the patient voice is absolutely critical in shining a spotlight on lung cancer in our families, in our communities, as well as within the broader medical science community. We can raise awareness. We can speak about things, some of the softer, deeper issues. So, it's one thing talking about patient, dealing with symptoms and the medical oncology side of things, but there are the softer issues, dealing with grief, advanced care planning. There's so many young people I meet that are still trying to raise a family. They're worried about paying off debt. So those are things that we can speak about because we've got the lived experience. And I look at how well I'm doing, and I'm not afraid to talk to anybody about my diagnosis. People will see me coming and running, but they don't guess that I'm living with stage 4 lung cancer. And it's 5 years and counting now. And what I've learned is that people hear lung cancer, they hear stage 4 lung cancer, and they see a picture of an older person, gray face and kind of hazy skin and smoke all around their heads. And it's really important for people to realize that, up to 20% of us can be diagnosed. So I think the patient voice is absolutely critical. And it's just tremendous that more of us are living longer. And there are just so many opportunities for us to have a voice and spread the word.
Thank you, Bev. How about you, Katie? Why don't you give us some of your perspective?
Yeah, for me, when I was diagnosed at 33. That's almost 4 years ago. And the initial prognosis was a few months and get your affairs in order, only to realize I had an ALK positive mutation, which really gave me new keys to life. And for me, what's really important is that we see a wide range of faces. So I love that this is called the Faces of Lung Cancer, because it's my face, which probably most people wouldn't recognize as being a lung cancer survivor, currently with stage 4 cancer. And I think it is really crucial to understand that there's a variety of people who can get it, from smoking to non-smoking, from young to older generations, from different geographics. And we really need to make sure that it is not seen as one type of cancer. We've talked about the stigma here. And for me, I shortly after wanted to start to advocate for equity in drug access, equity in the precision medicines that are available, and seeing how patients before me and continuing beside me have pushed to make changes in the system. I see what it looks like when an advocate and like the clinicians here, and we walk into a room side by side to talk with change makers and policymakers. It makes a big difference when you have that voice. The numbers are numbers, but when you have a story with a face, you can't deny that. And I would love just to see lung cancer just be seen equivalent to other cancers, where there isn't that stigma, and there's understanding that we can walk into a room now and we don't have to convince people. It's just understood that this is a disease that deserves its dignity, if you will, and by putting various voices out there, I think we will do that over time.
Let's talk a little bit about that concept of of hope, and I'll maybe open this up to anyone on the panel. You know, you guys have been through a heck of a lot. Where do you find hope? How do you define hope, and how have you found that inner resilience that is required to keep putting one foot in front of the other?
Yeah, I can talk about hope. Define hope. I would say that you have to redefine hope, because that was our case every day. This, the period of 6 months of my father, it started with thinking that he would perhaps be able to go back to work. We knew there was no cure, but we had that hope where he could spend more time with his grandkids. And a week later, that wasn't the hope anymore. So we had to redefine, as we were going, what was hope. And I'm not sure I have a definition, but I know now that there may not be one definition, and you have to, redefine it as you go. And as for resilience, someone told me one day that, my father passed away. So for me, grief is like a rock that I'm carrying in my pocket, and that rock will never go away. But as I get stronger, I notice it less. So for me, the way I stay resilient is by talking about my situation. And also, talking about screening. For me, screening is really important, because I'll never know, what would have happened to my father if we had screened him earlier. And that's hard for me. But being resilient for me is talking about it. Perhaps too much sometimes. People are like, oh my God, she's going again on that. But for me, that's what helps me personally.
Would any of the other panelists like to speak to hope and resilience?
Well, I think sessions such as this, the more information patients and their caregivers and their families understand about the huge progress. And I think about the progress that I've understood over 5 years, but to understand progress over the 20 years or the 50 years that we heard about when attending the World Lung Cancer Conference is really important, because it does give us hope. And one of the messages that I'm trying to share with fellow patients is there's so many advances. We have to live with the expectation that we're not going to die in 6 months or 3 years. I was initially given 6 months to 3 years, and here it is over 5 years. So I think we need to embrace the notion that we're going to live for at least 10 years, if not longer, and manage our life accordingly. So picking up on things that Ron mentioned, we take really, really good care of ourselves, because we want to be here 10 years from now. And I think that, if a patient and their family are hearing the negative side of lung cancer, not everybody is as fortunate. It's easy to get caught in the sadness and the grief. And I think it's just really important for us not to give up hope and keep fighting.
So in our last,
maybe could I just
go ahead.
jump in quickly?
Yeah.
Apropos of hope, watching Bev, I could suggest to patients and caregivers that they get involved, find out what they could do to get the word out about lung cancer and how serious it is and how much progress we're making. Bev decided early on, she said to me, I'm going to role model this. And that's what she's done. She's taken every opportunity she could to talk to patients. She's talked to pharmaceutical companies and organize events and raise funds. And I think that's made the journey a lot easier, because we have this satisfaction of making a contribution.
Maybe I'll give Katie the last word. Any key lessons that you've learned that might inspire others?
I think it's also just trying to find things that make you hopeful day to day. So I think a little bit of what Tanya said, which is sometimes you redefine it. And I just get so much joy out of knowing that in the morning I'm going to make myself a coffee or a matcha, or I have a call with a friend. And I think it just kind of reminds you that those simple things that you can create hope for yourself. um, I would absolutely agree with everyone else around how much progress is being made in the cancer field. That keeps me mostly hopeful. But to have something different to say at this point was really just try to keep finding things that make you hopeful every day to day, and bring you joy, because I think that when you have joy, you can have hope. So
What I talk to my patients about is the concept of redefining success, right? And success can be getting to that family reunion, seeing that
yes.
grandchild take their first steps. Again, getting together with your college roommates that you might not have seen in 5, 10, or 50 years, as it may be. And I think those are all important things. Sometimes people make it such a big, grand thing that they forget that little things matter. And that's the one thing that brings me joy about getting to spend time with each and every one of my patients, is getting to hear. The first thing I say when I walk in the room, and any one of my patients will know it, is what's new and exciting with you today? And that's what drives me each and every day, is all those what's new and exciting since the last time I saw you. And those are important things, not only for me to get to take hold of, but you to take hold of as well. And you're like, oh yeah, this is new and exciting. So I think that's a fun part of what we do. So I just want to thank our patient and caregiver panel. I appreciate each and every single one of you and everything that you do for the lung cancer community. So thank you very much for your time. I'm going to take these last few moments to wrap up our Faces of Lung Cancer briefing. I'd like to express my gratitude to each and every one of the speakers. I know how busy each of the physicians are. I know I've just asked patients and caregivers to take time out of their busy day where they're redefining their success. So just thanks to everyone who has participated in this. Your contributions are immeasurable. Today, we have gone through multiple key themes. We've talked about the pivotal role of equity in lung cancer, and we need to have accessible screening. So again, reminders, we've got that policy forum and screening that is coming up next week. So please sign up. We'd love to see you there. We've talked about innovative treatments. We've talked about robust support systems and making these things possible. We not only have looked at challenges we face, but the transformative power of advocacy, collaboration, and community engagement. We'll all remember the stories that have been shared by these patients and caregivers, and I will always be inspired by my patients and our patient advocates here. Their resilience inspires us to push for a future of lung cancer where we are in a world without stigma, and every individual has access to the care that they deserve. I would like to take the momentum from today's discussions, and hopefully this will translate into action. So please engage with Lung Cancer Canada, whether it's by supporting our advocacy efforts, spreading awareness, supporting ongoing research initiatives. These are all key features in what we do each and every day. I also want to remind folks, we just updated our comprehensive guide to lung cancer. This is an invaluable resource. Every single patient who comes to the clinic in Hamilton gets a copy, and I hope that that becomes the truth for every lung cancer patient across this country will get access to that guide. It actually has wonderful questions to ask your doctor, food for thought for people. So it's a wonderful resource. I want to highlight some of the other events that are coming. We have our Evening of Hope. It's a hybrid virtual and live event. So there are 6 different live parties that are across the country from east to west. That's Sunday, November 17th. I've already mentioned the Policy Forum on November 14th. We have an additional forum coming up in December on December 5th, talking about clinical trials. But we've also got a few other things coming. We've got one of our lung cancer summits. This has been a piece of pride in that we've revived this since the pandemic. So the next one is in Saskatoon. So that's November 20th. So looking forward to seeing advocacy in Saskatchewan. And then we have a webinar coming up for our 2 awards for Lung Ambition. So come and hear about some of the grants that have been funded with our Lung Ambition Award. That's on November 22nd. I once again would love to thank our sponsors. Again, this is something that we could not do without sponsorship. So thanks to AstraZeneca, thank you to Amgen, thank you to GlaxoSmithKline, thank you to Bristol Myers Squibb, thank you Gilead, thank you EMD Serono, thank you Janssen, thank you Merck, thank you Pfizer, thank you Novartis, thank you Sanofi, thank you Takeda, and thank you Titan One. Your sponsorship of today's event has been critically important. If you would like to see the entirety of the 2024 Faces of Lung Cancer report, it will be available on the Lung Cancer Canada website. So as we move forward, let's remain committed to raising our voices, advancing equity, and changing lives. Our collective efforts can and will make a difference. Thanks to everyone for participating today. Together, we truly can transform the landscape of lung cancer care. Have a wonderful day today. Take a moment on Monday to honor our soldiers for Remembrance Day, and then keep coming back for all of these wonderful events. So I look forward to seeing you at the upcoming Lung Cancer Canada events in November. Have a great day, everyone.